Thank you very much. I am Dr. John from West Sumatra. I would like to ask the question for Mr. Prof. Lawrence. Prof. Lawrence, according to Dr. Chokorda, said that Indonesia has the diversity for 3 tribes and 13 tribes, sub-tribes that included in the whole of the entirety of Indonesia. For example, I always read your book, for example, just like cultural consultation, that encountering the other in mental health, your book, Mr. Prof. Lawrence. And according to the lack of the diversity of the culture and the tribes and the language included in Indonesia, how we can overcome as the practitioners. For example, you said in the page 48, you said we should use CCS. CCS are just like using the triangle, interpreter, the psychiatrist, and other culture broker that could use to intervention the cultural intervention for the family and the other. Please give us the brightness how to overcome the lack of the diversity that must be the advantage for us to go through the next times. Thank you very much.
Well, thank you very much for that question. So the situation you're describing in Indonesia, of course, is tremendous diversity. Even though you have, Bahasa Indonesia to have a language that you can use across different cultures, in fact, many people are mainly comfortable in their own original language, in their mother tongue, as it were, and you have many different ethnic groups, many different traditions. So we have a lot of diversity in Canada too, not on that scale, but that is the challenge that we faced at our hospital, for example, where 65% of the people living in the neighborhood around our hospital were born outside Canada and come from other countries. So when we see a patient, they might have come from somewhere else recently. We might have no language in common. They might speak only a little bit of English or French, which are the 2 common languages here. So the first step in that for us is to have interpreters available, because if we can't communicate at all with people, then we're really doing very poor healthcare. We really have to guess what the problem is, and we may make mistakes, and we can't help the person to understand what we're offering and to trust us and to tell us what's going on. So that's pretty basic, and I think developing interpreters, not just using a family member, which we sometimes have to do in an emergency when there's nobody else around, but developing colleagues, people around who are trained interpreters, understand the kinds of questions that we need to ask in mental health, to be able to do a mental status exam, to be able to know what's really troubling people, and who can work as part of the team. So that's one kind of resource that has to be developed. If we have practitioners, people, health practitioners who come from different areas who have the language skills already, that helps a lot, but it's not always possible. The cultural broker part goes beyond linguistic interpretation, because it's not just about understanding each other, but it's understanding the kind of community we live in, the kind of way that we see the world, what we were talking about earlier in terms of different worldviews and ontologies. So that is takes a bit more skill and a bit more, or different kind of skill, I guess, and an ability to think about and talk about what things mean, what words mean, and what problems mean in a particular situation. In our setting, because we have migration, sometimes those cultural brokers are people who came from somewhere else, from the same place as the patient. Sometimes there were health professionals there, and they can't get the accreditation, or it takes a long time to do that here, so that they are able to still help their community do interesting and very important work while they're in that in-between place. But developing that kind of skill of culture brokerage, which again, some of us can do if each person has their own background and they have certain special knowledge. They come from one region of Indonesia or another and they have certain knowledge they can use, so they can help to do that. The goal is to share that with colleagues so that we all improve our skills and we all have a way of exploring what's going on with the patient. And we have some very simple tools to help us in that process. We have an outline for cultural formulation that was developed in DSM-4 and DSM-5, and it's readily available. We have a cultural formulation interview, which is just a simple way to begin to ask questions about what the person thinks the problem is, what their family thinks the problem is, what kind of help they think would be helpful. These are very important information to have to be able to communicate with people and to negotiate an approach that makes sense to them and that they're going to be able to use. So that is an approach that says we have certain knowledge that we've acquired from studying psychiatry and psychology and social work and other disciplines, but we have to be engaged in a process of communication and translation of that to make it fit the situation. And that is a two-way process. It's not just us telling other people, telling our patients what we think they need. It's listening to them and figuring out with them what is the particular situation that they're going through. The more that you do that with people from a certain background, the more familiar you get, the more you already know a little bit what questions to ask. But you can never assume. If you just know, oh, you have a label, you're from such and such group, it doesn't necessarily mean they might have been from that group but grown up in Jakarta. Their situation is very different than if they grew up on a remote island where they're not having the same kind of environment. So we always have to do a certain amount of keeping an open mind and asking the right questions to begin to get the story, and use that then to figure out, so where does our specialized knowledge fit in this picture? And I think if we take the time to do that, it takes time for sure. It takes more time than just asking a few questions and writing a prescription or something. But if we take the time, then the chances are we'll be able to be much more accurate and much more complete in what we do, and hopefully have much better outcomes. We'll also have a much higher level of trust with the people we're working with. So if our first approach doesn't work, we can figure out what's the next step with people and have that collaborative relationship. So I think that's, to me, the beginnings of a very person-centered approach that really takes the individual person in front of us and their family and their community, takes it seriously and tries to figure out what's going on. And I think that's a great way for us to train ourselves, and then as much as possible the best way to deliver services. But of course we always have to make compromises because of time and resources and so on. But still, knowing what a more complete approach would look like and then doing what's practical, I think, is better than just starting with a very minimal approach and not having this bigger picture approach to how we understand problems. So I hope that addressed your question. The book that you're referring to is readily available. If anybody needs to get hold of it, let me know. And there are discussions, as a chapter in that book specifically on cultural brokers and trying to give examples of how to use this approach to complement the regular mental health care system.
Okay, thank you very much, Prof. Lawrence, for